Alrighty, my name is Lexi Graham, and we are going to talk about acute respiratory distress syndrome in this video. This is video number 3 in the 6-part video series. We're going to talk about anatomical alterations of the lungs with ARDS. So ARDS causes the pulmonary capillaries to become engorged, and the permeability of the alveolar capillary membrane increases. Interstitial and intraalveolar edema and hemorrhage ensue, as well as scattered areas of alveolar consolidation. This process results in decreased alveolar surfactant and alveolar collapse. The major pathological or structural changes associated with ARDS include interstitial and intraalveolar edema and hemorrhage, like I just said, alveolar consolidation, intraalveolar haline membrane formation, pulmonary surfactant deficiency or abnormality, and then atelectasis. Etiology and epidemiology. About 10.4% of all ICU admissions are ARDS patients, and 23.4% of them are mechanically ventilated patients that have ARDS. Causes of ARDS include aspiration, sepsis, severe pneumonia, COVID-19, head, chest, or other major injuries, and then breathing in harmful substances. Clinical manifestations and symptoms include shortness of breath, labored and rapid breathing, cough, chest discomfort, diaphoresis, tachycardia, confusion and extreme tiredness, cyanosis, low blood pressure, bilateral crackles, and accessory muscle use. So the diagnostic criteria for ARDS, it's important to rule out other possibilities when diagnosing ARDS. A few things that aid in diagnosing it would be if the patient is hypoxemic and respiratory failure or showing bilateral lung infiltrates that is not caused by fluid nodules or lung collapse. Another way to diagnose would be the Berlin definition, which is explained as follows. Respiratory symptoms associated with ARDS have developed and worsening within 1 week of a known insult or new or worsening respiratory symptoms. The severity of ARDS is determined by how hypoxic someone is. This is determined by the ratio of arterial oxygen tension to the fraction of inspired oxygen, which is our PF ratio. The severity scale for ARDS, so mild, a PF ratio would be greater than 200 but less than or equal to 300 millimeters of mercury. Moderate would be the PF ratio is greater than 100 but less than or equal to 200 millimeters of mercury. And then a severe PF ratio is less than or equal to 100. General management, and then the 5 Ps of ARDS therapy. So ways to manage ARDS include mechanical ventilation, oxygen therapy, prone positioning, meds including sedation or paralytics, fluid management. For very severe cases, you can use ECMO, and even a lung transplant could be an option. The 5 Ps of ARDS therapy would be, so first is perfusion, ensuring oxygen is moved into the blood and throughout the body, making sure our organs stay alive. Positioning, use proning to reduce the pressure on the lungs. Protective lung ventilation would be low tidal volumes, high PEEP to prevent lung stress and strain. Protocol weaning would be assessing the patient's ability for ventilator weaning, and then preventing complications, taking steps to prevent stress ulcers, venous thromboembolism, and other complication. Thromboembolism, sorry. Pre and post CT of ARDS. So first we're going to start with CT. Next we have a chest x-ray. So a CT scan of an ARDS patient in prone position typically shows more even distribution of lung aeration compared to a supine position, indicating improved ventilation through the lungs due to the redistribution of lung weight, which is considered the primary benefit of prone positioning for the ARDS patient. This can be seen as a decreased difference in density between the dorsal and ventral lung regions on the CT scan. So this is the patient before you are proning them, and this is them after, so you can see a lot more aeration in there. And then the pre and post chest x-ray or chest radiograph of ARDS. A pre-proned ARDS chest X-ray would typically show diffuse bilateral alveolar opacities, including the white lung appearance, with potential areas of increased density in the dependent lung regions, usually the posterior bases due to the fluid accumulation. While a post-prone ARDS patient might demonstrate a redistribution of these opacities with improved aeration in the posterior lung fields and potentially new opacities appearing in the anterior regions. As the prone position allows for better aeration, the previously dependent lung areas, leading to improved oxygenation. So in this first one, you can see it's very white, and then the second one, you can see where it starts blackening up a little bit, seeing that's the air, more air getting into the lungs. So in summary, ARDS equals a decrease in compliance. So ARDS patients have very stiff lungs. So whenever we are, if they're on mechanical ventilation, like that 2.23-ish% of patients that have ARDS are on a ventilator, we want to make sure that we are doing protective lung protocol whenever we are mechanically ventilating them with those low tidal volumes and high PEEP. You diagnose ARDS based on the PF ratio. When the respiratory symptoms associated with ARDS have developed and worsening within 1 week, there are known insult or new worsening symptoms. That is the best way to diagnose ARDS. And then the ways to manage will be to ensure the patient is getting enough O2 in their blood and through their body. Position patient prone, take pressure off their lungs. Like I said, the low tidal volumes, high PEEP, to prevent the stress or strain on their lungs. Assess their ability to wean, and then take steps to prevent complications such as the ulcers or pulmonary embolism. These patients are very delicate, and we need to make sure that we do not blow their lung. That's why we're using the low tidal volumes to ensure their best safety, especially when we are mechanically ventilating them. Thank you.